Just published April 15th, 2026, the Congress of Neurological Surgeons' newest guideline on treatment of adults with World Health Organization, or WHO, Grade 2 diffuse glioma. This guideline is an update of the evidence-based guidelines for management of WHO Grade 2 diffuse gliomas published by the Congress of Neurological Surgeons and American Association of Neurological Surgeons in 2015. In today's rapid update, we'll just be going over new and updated recommendations. So for the full guideline, make sure to check it out on guidelinecentral.com. Let's get started. Starting with the section on imaging. The use of diffusion imaging and dynamic susceptibility contrast, dynamic contrast enhancement, and arterial spin labeling sequences is suggested to differentiate WHO grade 2 diffuse glioma from higher grade gliomas when this is not accomplished by T2 weighted and pre-gadolinium and post-gadolinium contrast-enhanced T1 weighted imaging. The use of diffusion and perfusion is suggested for obtaining information in genomics, prognosis, and post-treatment monitoring when this information would be of value to the clinician and is not obtained through other methods. The use of MR spectroscopy is suggested to differentiate WHO grade 2 diffuse glioma from higher grade gliomas when this is not accomplished by standard MRI, perfusion, and diffusion techniques, and when such information would be of value to the clinician. If not already evident by MRI studies, the addition of amino acid positron emission tomography, or PET, with fluoroethyl L-tyrosine and dihydroxy-6-fluorophenylalanine as a tracer is suggested to help determine if a brain lesion is a low-grade glioma or a high-grade glioma. If the standard clinical prognostic parameters are unclear and novel PET tracers are available, the clinician may consider fluoroethyl L-tyrosine to assist in determination of prognosis in an individual with grade 2 diffuse glioma. Clinicians may use dihydroxy-6-fluorophenylalanine PET in addition to MRI if additional information is required for detection of tumor progression. Next, the section on surgery. In adults with imaging suggestive of a WHO grade 2 diffuse gliomas, surgical resection is suggested over observation or biopsy to improve overall survival. In adults with imaging consistent with a WHO grade 2 diffuse glioma who present with seizure activity, surgical resection of greater than 90% of the lesion, when it can be accomplished safely, is suggested over observation or lesser extent of resection/biopsy to improve seizure control. It is suggested that extent of resection be maximized as is safely possible for isocitrate dehydrogenase mutant and isocitrate dehydrogenase wild type WHO grade 2 diffuse gliomas to improve progression-free survival, or PFS, and overall survival, or OS. There is insufficient evidence that greater extent of resection of 1p19q co-deleted oligodendrogliomas improve OS. The use of intraoperative ultrasound is suggested to increase the extent of resection compared with the conventional surgery for adults with WHO grade 2 diffuse glioma. Intraoperative fluorescent guided surgery with 5-aminolevulinic acid is not suggested to improve the extent of resection for WHO grade 2 gliomas. It is suggested that awake craniotomy and other methods of intraoperative mapping can be used to increase the extent of resection for adults with WHO grade 2 diffuse glioma. The use of functional MRI and diffusion tensor imaging related modalities are suggested to decrease surgical morbidity in adults with WHO grade 2 diffuse glioma. For the section on pathology, there is insufficient evidence to recommend alpha thalassemia/mental retardation X-linked mutation testing as a means of predicting survival or making treatment recommendations. There is insufficient evidence at this time to suggest that intraoperative optical histological methods offer increased diagnostic accuracy when compared with conventional techniques. On to the section on chemotherapy. It is recommended that chemotherapy be added to RT in all patients with newly diagnosed high risk WHO grade 2 diffuse glioma to improve their overall survival. It is recommended that chemotherapy be added to radiation therapy in all patients with newly diagnosed high-risk WHO grade 2 diffuse glioma to improve overall survival without a decline in neurocognitive function. It is recommended that chemotherapy be added to RT in all patients with newly diagnosed high-risk WHO grade 2 diffuse glioma to improve progression-free survival and overall survival. It is suggested that chemotherapy alone should be considered in patients with newly diagnosed WHO grade 2 diffuse glioma in cases with 1p/19q codeletion. Neoadjuvant temozolomide may be used in patients with WHO grade 2 diffuse gliomas deemed unsafe for resection due to infiltration of eloquent areas or with large contralateral extension as an initial step to improve the extent of resection. There is insufficient evidence to support a recommendation regarding the ability of chemotherapy provided before surgical resection to improve PFS and OS. There is insufficient evidence to support a recommendation against the use of temozolomide for WHO grade 2 diffuse gliomas due to concern over increasing the rate of malignant transformation. There is insufficient evidence to support a recommendation for or against the use of multi-agent chemotherapy to improve progression-free survival and overall survival when compared with administration of single-agent chemotherapy in patients with newly diagnosed WHO grade 2 diffuse glioma. And lastly, section on radiation therapy, there is insufficient evidence to provide guidance on the superiority or inferiority of proton radiation effect compared with standard radiation therapy on WHO grade 2 diffuse glioma for overall survival, progression-free survival, local control, complications, neurocognitive preservation, and quality of life. It is suggested that 1p/19q deletion status be used as a positive prognostic indicator regarding the effect of radiation therapy on progression-free survival and overall survival for WHO grade 2 diffuse gliomas. And there you have it. Make sure to check out the full guideline from the Congress of Neurological Surgeons and other related clinical decision support tools at guidelinecentral.com.